everyone. This is Samira Daswani, the host of the podcast, The Patient from Hell. Today, we're going to continue our discussion with Dr. David Penson, who is joining us from Tennessee and is wears many hats. One of which is the director of. I'm going to botch the institute's name, so you may have to help me. Can you actually just tell the name of your institution?
So I'm at Vanderbilt University in Nashville, Tennessee.
Uh-huh.
Which for your listeners who care about SEC football is the home of the Vanderbilt Commodores. I'm here in the Department of Urology.
And you wear a health services research hat.
Yes, that is correct. I also am the director for our Center of Surgical Quality and Outcomes Research.
There we go. That was the institute, which the name was escaping me.
It's too many titles, and I don't mean that in an arrogant way. I mean that in whatever.
Hard to describe your bio way. I understand. So where we left off with part one is in part one, we explored a whole host of things. We defined the types of research that Dr. Penson does, including comparative effectiveness research. We compared and contrasted breast cancer and prostate cancer from a cultural lens, a stigma lens, and then we really went into screening for prostate cancer and why screening is such a complicated beast in prostate cancer. The data is not clear. There have been multiple studies. The PSA test has drawbacks, and how screening today is really decided at the individual level between a primary care physician, maybe an oncologist, and an individual. And how that while that's good from a personalization of medicine perspective, that has just inherent problems with it, which is you can't really standardize care across different settings. So that's kind of where we left off. What we were going to do today is explore decision-making in prostate cancer. And we were going to start with this tension between overdiagnosis and overtreatment. So maybe we'll start with overtreatment. If you can talk a little bit about that, and then we can come back to overdiagnosis.
Yeah. So let's go there, and we definitely should get back to the screening discussion. But I'd rather talk about the overtreatment piece because that's where my research has really been focused, and where I think, I've always felt that's where you can make the greatest impact for patients. So when I was a resident, so I've been in practice, I graduated residency in 1997. Hopefully I don't look that old. I don't feel that old. Basically, if you were diagnosed with prostate cancer, you were getting treated. If you were healthy, relatively healthy, you were either getting surgery or getting radiation. There was no real nuance to it whatsoever. And if you look at, patients diagnosed with prostate cancer, significant number, depending on which population you look at, is going to have low-grade disease. And those patients, they do well no matter what you do. When I talk to patients, and I still have a clinical practice, it's pretty much prostate cancer, and I see someone with low-grade disease, and we're talking, they come in, I have cancer, and what do I do about it? Oh my God, I say, you have low-grade cancer. This is probably not going to be a problem. We can follow this very closely. There are ways we do this. And well, you got to treat me. And then my comment is always, I could give you a pack of lifesavers, tell you that it's a magic medicine, and you would do great. And you think I'm the greatest doctor in the world, because low-grade cancer for the almost never causes problems. I say almost never because there are exceptions. That's why we do active surveillance. But we had this situation where, we were overdiagnosing, half the men who were detected by PSA screening at the turn of the century were overdiagnosed, depending on how you defined overdiagnosis, and they were all getting treated. So you had this, terrible problem where, we were just kind of treating everybody. I think what we've learned is that, in fact, not everyone with prostate cancer needs to be treated. That PSA picks up a lot of clinically indolent prostate cancer. And we had that feeling all along, right? But I don't think people are ever really willing to dive into the pool and say, okay, let's think about treating this differently. And to the credit of I think it's, started, frankly, there are some places in the U.S. who drove it, but the Canadians really were very forward thinking in this, and the Australians too. Um, they started saying, well, let's do active surveillance. Let's follow the PSA, because PSA as a tumor marker, like I said in part one, it's a great tumor marker. It's not perfect, but it's really good. And let's do repeat biopsies. Make sure we're not missing anything. And I'm not saying biopsies are fun. They're not.
Mm-hmm.
I'd rather not have one if I ever need one, but it's certainly easier than having surgery or radiation for prostate cancer. And what we found was, patients, if they were adherent to these protocols, were doing great. Now we have 10, 15-year follow-up, and, the majority of patients are alive, are staying on the protocol and doing really well. So we've gotten away from overtreatment, but the art has always been figuring out who needs treatment and who doesn't. And that's been a focus of a lot of people's research, not so much mine. We know that patients with lower grade disease, pathologic grade, are going to do better. There are some genomic tests out there, which some people are big fans of. I think it's a mixed bag. I think they're helpful in some patients, but it's the minority of patients. Imaging, MRI imaging, can be helpful there too. So I think we've become more sophisticated in identifying which patients are at risk for having what is a quote unquote clinically meaningful cancer versus those who are not at risk. And that's helped us with overtreatment. But
Can I ask you to define low grade?
sure. Okay. So yes, I can. So really low grade, there are a bunch of different, low risk versus low grade. Low grade's easy. Low grade is pathologic grading, and that's Gleason 6 disease. So grade group 1. For folks who don't know the Gleason scale, the Gleason scale has been around since, frankly, before I was born, and I'm in my 50s. And basically, it is a scale that looks at the most common pattern and second most common pattern of tumor cells in prostate tissue. And it used to go from 1 to 5, with 1 being the best, 5 being the worst. It's sort of evolved, and now it goes from 3 to 5, with 3 being the best, 5 being the worst. So you can have a Gleason sum from 6 to 10. And 6 is 3 plus 3. 7 can be 3 plus 4 or 4 plus 3, which is more common, right? Remember, the first, I may not have said this, the first number is the more common. So you may be 51% 3, 49% 4, or 99% 3, 1% 4. Either way, you're 3 plus 4. 4 plus 3, more 4, etc., so forth.
Why are there 2 numbers?
So prostate cancer is heterogeneous. So it's not like, if you look at a prostate tumor, you're going to have different cell lines in it. And some of them look angrier than others. And so that's why they do that. The analogy I use when I talk to patients, and I'm not a pathologist and don't claim to be one, but I'm a simple guy. And when I talk to patients, I'll just say, look, it's kind of like soft serve ice cream. If you go down and you get vanilla and chocolate ice cream and soft serve on a cone, you got that swirl, right? So the amount of vanilla and amount of chocolate that's in there is what the number is. The first number is the most common pattern. The second number is the second most common pattern. Some pathologists report out tertiary patterns too, but that 3 plus 4, 4 plus 3, that's the number that matters. So a low grade cancer is 3 plus 3 equals 6.
Got it. Okay. All right.
And there are people out there, I am in this camp, although I'm not as dogged as others, but I am definitely in this camp, that we should rename Gleason 6 cancer to not include the word cancer. That it should be, a neoplasm of indeterminate significance. Or some other, kind of like maybe DCIS, maybe in prostate. I don't know if that's quite the best analogy. If you look at low-grade thyroid cancer, they renamed that completely. Pathologically and biologically, I'm kind of really going down a very technical road here. Pathologically and biologically, Gleason 6 has all the signs and hallmarks of cancer. and you lose your basement membrane, you lose, so I won't argue that pathologically it looks like cancer, but there's pathologic sort of orthodoxy and clinical pragmatism, and I'm in the second camp. The vast majority of men, maybe not 100%, but the vast majority of men with Gleason 6 disease, if it's truly Gleason 6 disease and they're followed in active surveillance, it's not going to metastasize. It's not going to spread. It's not even going to cause local symptoms. So to me, why are you calling it cancer? Because when you think of cancer, if you look up the Webster's definition, it's something evil that spreads.
Yes.
All right. And that's what patients think of. I don't care what doctors think of. I think about what patients care about, right? And so I get it. I'll acknowledge any pathologist who's listening who wants to say it is cancer and it's got this sign, this sign, this sign. You are right. But I'm a clinician and I'm pragmatic here. And it's time for, I actually wrote an editorial, so I didn't just think this up, clinical pragmatism should win over pathologic or biologic orthodoxy. I'm there, but I get it. Not everyone wants to go down that road, and that's fine. But that being said, this low-grade disease, low-grade prostate cancer, it doesn't behave like high-grade prostate cancer, the higher numbers. And the majority of them probably don't need to be treated if it truly is low-grade disease.
So can I ask you a question? So it's not that you're saying there's nothing you're doing in that population, right? You are doing something, which is active surveillance.
That is correct. And that's a key point. So it used to be that we would talk about watchful waiting, where basically I used to always make a joke, we're watching and waiting for you to die. Come back when you have a symptom. All right. Well, you don't want to have metastatic prostate cancer. That's one of the reasons why USPSTF went from a D to a C. Active surveillance is actively following the tumor. So you're getting your PSA checked every 6 months. You get repeat biopsies to make sure it hasn't gotten worse, that we're not missing anything. And yes, probably depending on which cohort you look at, up to 1 in 5 men and how long you follow it out are going to be on active surveillance, are going to end up getting treated. Taking the UK cohort from PROTECT aside, which is a different cohort entirely, truly Gleason 6 at baseline, the vast majority of men, if they stay on active surveillance, they don't get treated.
Wow.
And you're not doing nothing. You're not doing nothing. And now the other thing that people are adding to it is MRI imaging, which I think is, and we can talk about screening, because I think MRI imaging has changed things a lot. And you put them together, and if I had low-grade disease, there's no doubt in my mind what I would do, which is active surveillance, because the side effects of surgery and radiation are not things that I want to deal with unless they're going to prolong my survival and minimize clinical cancer side effects. So
actually, where you just went is kind of where I want to start, which is you have Gleason 6, active surveillance being defined as 6-month PSA, regular biopsy, maybe imaging in there with MRI. Let's say you have a higher Gleason score. So not so much low-grade disease, maybe mid or high-grade disease. I also don't know if that's technically accurate, by the way, so please correct me.
No, it is roughly. Yeah. Roughly.
Okay.
Well, we start getting into quote unquote risk groups, which incorporate PSA values as well. So if you have Gleason 6 and your PSA is 25, I'm missing something. There's something else going on. You probably have higher grade disease, assuming you don't have a big prostate. So it's a little more nuanced, but go with that because you're spot on. Let's talk about the guys who have Gleason 7 and higher. Talk about the higher PSAs.
So in those populations, the first question I have is why are we only talking surgery radiation? Like, where is hormone therapy? Where is chemotherapy?
Sure.
Why aren't those modalities kind of part of the narrative for one?
All right, that's a really important question, and there's another piece to it that we haven't really talked about, which is localized disease versus advanced disease, right? And we haven't talked about the sort of novel therapies, things like high intensity focused ultrasound, cryotherapy. But let's start by talking about we're specifically talking about localized disease. Screening has resulted in a stage migration with the majority of men presenting with disease localized to their prostate.
Got it.
And that's the difference. And when you're talking about disease which is just in the prostate and hasn't spread anywhere else, I'm not aware of any studies that show a benefit to upfront hormonal therapy or upfront chemotherapy as far as survival. And in fact, upfront hormone therapy over a long period of time may negatively affect other cause survival because there may be a cardiovascular effect to it. So with localized disease, and I know there are some clinicians out there who will see this 90-year-old guy with, intermediate risk disease, low risk disease, but particularly intermediate risk, to say, I'm going to put you on hormones. That may make the patient feel better. That may make the clinician feel better, but I'm not sure you're ultimately affecting the outcome in these older guys. In younger men, what do we have data on, right? As far as clinical, cancer outcomes, patient-reported outcomes. We have really good data on surgery, really good data on radiation, not necessarily in the same study, but we have data, long-term follow-up for both. We're generating active surveillance outcomes now out to about 10, 15 years. Don't have as great a database around high-intensity focused ultrasound or even cryotherapy. So I think in the end, people go back and say, okay, you have high-grade disease. You have Gleason 8 disease. We caught you early. You're a lucky guy. You need to be treated. You're 55 years old. We found you with Gleason 8 disease. If you don't get this treated, there's a real possibility you're going to live another 20, 30 years, and this is going to cause you some problems. You were lucky you got screened. That's the screening winner right there. And that's the guy who's making that hard decision. How do I want to treat it? Because in prostate cancer treatment for local disease, there's no free lunch. If you look at the three big categories, I'm going to put aside the other ones because I don't think we have as much data. I don't want to dismiss them, but there's no free lunch with any of these. There's sexual side effects and urinary side effects with surgery. There's urinary side effects, bowel side effects, and maybe sexual side effects with radiation. And with active surveillance, you may not have those side effects, but there's a lot of anxiety for patients. And so it's kind of picking your poison, right? How are you wired? And that's really where, from a research perspective, I've really kind of focused in on. Because to me, all things being equal, as far as cancer control and cure, and I'm not entirely convinced, that's my surgeon hat coming out for a minute, but certainly they are out to about 10 years. What's the risk benefit equation for you? And how do you choose what you want to do, right? And how do we get that information to you in a way that you can sort of digest it, right? And so it's really, and it's hard. It's really hard. I don't want to overshare. I was just on the phone with a friend of mine, an old friend of mine, someone I've known for 30 plus years, who was just diagnosed with real unfavorable intermediate risk prostate cancer, 4 + 7 disease, and I said to him, I said, here's what I would do, but my preference set may be different than yours, right? And I think that's the real nuance to prostate cancer care, localized prostate cancer care. I mean, that's what I love doing, both from a research perspective and a clinical perspective. Because if you can help, I shouldn't say make, but if you can help a guy make a decision that makes sense to his preferences, that's a huge victory, and.
I would love for us to go to where you just went, which is preference at, because we've been recording a number of podcasts right now on decision making, and the notion of a preference set, I think, is something that is, I'm almost certain, not common language in the patient population. Because when you get diagnosed with cancer, the idea that you have a preference and the preference matters is very, very difficult to wrap your head around. It's just such a foreign concept, right? Because and I remember this, I distinctly remember this, where I got diagnosed. One of my professors is a survivor. Ended up in his office because, I mean, I was 13 when I got diagnosed. I don't know people who had cancer. Everyone was much older than me. Ended up in his office, and he had a head and neck cancer. And he sat me down. He goes, just remember that if you have 6 cycles of chemo and you're sitting in that 5th cycle and don't think you can manage it, you can say no to the 6th. And I just remember being like, what are you talking about? What do you mean I can say no to the 6th? Like, it's 6 cycles. Of course I have to finish the 6 cycles. And I remember like 3 months later, 5th cycle, and I was like, I don't know if I have another cycle in me. Like, I don't know if I can do this for another cycle. And I remember being like, he had told me this many months ago, and here I am sitting, and I don't know if my preference, if my opinion, if my quality of life matters to this decision. And eventually I got over it, and hence the podcast name, Patient from Hell, there was definitely an evolution there. But it's a very hard thing for, I think, patients to wrap their head around. And I'd imagine it's not just the patient, it's the family too, because patients are not making decisions independently, right? You kind of have this group of individuals kind of who show up. So I'd love for you to talk about that, like define it, explain it, any sort of thoughts on that.
It's so this is one of the things where maybe prostate cancer is ahead of a lot of other cancers, because it's all out there, right? The idea of saying, okay, I've had 5 cycles, I don't think I can do the 6. That's real. But a lot of patients are just going to say, look, I'm not choosing, you're choosing between something and nothing there. In prostate cancer, you're choosing between something and something, but each one has a side effect, and you may be choosing to not be treated at all. I mean, I had a patient, he's since passed, who had advanced prostate cancer, and this is 10, 15 years ago, and it was before the Sepolia T, the prostate cancer, the first immunotherapy in prostate cancer, which now has been sort of lapped by other treatments, was approved. And he's like, well, what if I pay for it myself? I'm like, all right. I mean, I'm not sure it's worth it for 3 months, 4 months survival benefit, but that's up to you. And when I told him it was $40,000, out of pocket, he's like, yeah, I think I'd rather give that to my kids. Right. So, and that's a whole other thing, financial toxicity, which is, but with prostate cancer, it's really interesting because I think patients they may not be specifically addressing it as a preference set, but I think they're aware. And the reason I think they're more aware, and the reason is because it's out there and people talk about it. People know that the side effects of surgery, if they don't know when they first get diagnosed, they find out really quickly. It ain't good for their sex life, and it may affect they may leak urine, right? Those are the 2 big side effects of surgery. Radiation, is not going to affect their urine as much, may affect their sex life, but to a lesser degree, according to our research and many others, but may affect their urine function, may affect their bowel function. And, there's the cancer control and cure piece is not quite as clear because you're not pulling the cancer out. So you don't have the psychological benefit of knowing what you're dealing with, and it's very hard to do surgery after radiation. So it becomes this sort of set of options, set of what's important to you, right? So patients may not walk in the door saying, I have a preference set, but as you start talking to them, their preference set becomes really relatively clear. And when I talk to them, I say, listen, I can tell you what I would do, because a lot of times I say, Doc, what would you do? Yeah. But the problem is I can't take Dave out of Dr. Penson, right? So I say, I have my own set of preferences. Here's what's important to me. And one of the things that we've done with our data from our Big Caesar study is we partnered up with a guy at UCLA, a friend of mine named Chris Seigel, who has developed a decision-making tool through a company called Wiser Care, and he's tied to it. I'm not, but they incorporated our data into their tool, and it uses something called conjoint analysis, which comes from schools of business. But to really explicitly help the patient understand what his preferences are in terms of sexual function, urinary function, bowel function, time receiving therapy, time off of work, to some degree cost of therapy, cancer control, cancer cure, and it's a cool tool for patients to think it through. Now, the one thing I will say, now I'm going to get my geeky HSR hat on because I do love this stuff. You get into utility theory, right? Which is preferences as well. What is the utility of this to you, that? And if you go back to the original utility theory, as it was put out, one of the tenets was that the decision maker is a cold, hard, rational thinker, right? So in other words, it's not an emotional decision. It's just A versus B. And when you've been told you have cancer, the majority of people are not cold, rational thinkers, right? And so that's part of it. There's another piece to it. Now I'm just kind of rambling, but like I said, I love this stuff that you raised, which is it is the patient's decision ultimately in prostate cancer. But he's not the only one in the room. And often there's a spouse in the room. And traditionally, my experience is the patient will walk in the door and I'll see the patient alone and he'll say, okay, I need some time to think about it. My sexual function is really important to me. And this is, and I'm going to come back with my spouse. The majority of the spouses are female. And they come back a month later and they sit down in the room, and again, it's usually the wives will say, he's having surgery. When can you do the operation? And I'll look at him, and he's kind of sheepishly looking at me, and I know he's thinking, and the comment from usually the wife, again, I'm being a little politically correct here, but I think it's important in this day and age. The wife is, we don't even have sex that much anymore. Okay, I just want that out of him. I want the maximal chance of cure. And for a lot of these men, it's not just about having sex. It's knowing that, so again, it's a preference set, right? I know what my preference set is, and I'm not going to share it because that is TMI. But the reality of it is that, I think for a lot of these men, part of the decision-making process is helping them to at least in their own mind make some explicit value decisions, preference decisions around their sexual function, their urinary function, their bowel function, their desire for cancer control and cure, the peace of mind or lack thereof that goes with that, financial toxicity, how their family is going to react, time off of work, which I guess is part of financial toxicity, but not necessarily. I mean, there are all these different pieces that go into it. And that's really, to me, what I'm fascinated by at this point in prostate cancer, because I think we can do better, and, it's not black or white. And the other problem is, and I should acknowledge this up front, the clinicians have biases, right? So I'm a surgeon, all right? It's an honest bias. It's not about the bottom line for me. I'm an employed physician, but it's still a bias, I mean, and studies again and again show that surgeons talk about surgery, radiation oncologists talk about radiation, and never the twain shall meet. And it's hard for me, even as someone who thinks of himself as an enlightened prostate cancer clinician, not to let my bias seep into my discussion,
This is fascinating.
And there's another piece to it, by the way, which is patients become biased too. Yes. So I tell patients this all the time, because then they go to the internet, they start with Dr. Google, and Dr. Google, you got to see who Dr. Google's working for, because they see a lot of ads, and it's not always clear that the ads are being put out there by this center or this that, and so that's not always clear. But they go to support groups, and support groups are great. I'm not knocking the support groups, but I always tell patients, once you make up your mind about a decision and you have that therapy, you be more often than not always, you become the biggest advocate of that therapy, because it's cognitive dissonance to say, wow, I should have done it differently. So it's like finding religion, right? Everyone loves, I'm not a particularly religious person, but I live in the South, which is a highly religious place. And, everyone loves their church on Sunday, right? And so once you choose your church, that's where you're going. Once you choose your therapy, the majority of guys, will advocate for it, unless they have a bad outcome, in which case they'll advocate against it. And again, that may not be valid either. It may be a one-off. So it's fascinating.
So I have to. I am a nerd when it comes to this stuff. I absolutely love decision science. I've loved it before my diagnosis and post-diagnosis. Absolutely love it, because I think there were a couple of things you said that I think I would love to sort of circle back to. The idea that you're not rational. I mean, you're never really rational. That's beside the point. But in the scale of like irrational and rational, if we think of it as a spectrum, that cancer diagnosis definitely puts you in this bucket. Like, there is no two questions. There's no.
Oh yeah.
That. The question is, how do you then take that patient or enable that patient to move towards the rational side, right? Because it's not happening in the appointment. It's definitely not happening with Google. And decision aids are great, but decision aids in the absence of a clinician walking you through that, I think, is hard. And the problem I have with decision aids is it's a point in time decision aid.
Oh yeah.
Right? So you have to capture that patient at exactly that point in time when they're making that decision, unless your decision aid is smart enough that it's evolving with the patient. Right? Because if I were to make a decision, and I'll give you an example of this. If someone told me, actually, no, this is real. In my case, standard of care or guideline-based therapy suggests neoadjuvant chemotherapy. So chemotherapy before surgery, you look at, and then you do surgery. Again, standard of care is lumpectomy followed by radiation. Lumpectomy decides whether you had a pathological complete response. If you do, yay, good, you just move on to Herceptin. If not, then you sort of escalate treatment. And I was so emotionally against neoadjuvant chemo. And for full context, I was that patient who like walked in the door and I was like, Doc, I need you to give me, your up-to-date thing that you get access to so I can read all the papers, right? So I was that patient.
Right.
I read everything. And
you are the patient from hell, but that's okay. No, you're not. I'm just giving you grief.
Oh, don't worry. I am self-proclaimed. I drove my care team nuts, but they didn't abandon me. And I think we have a good relationship still. So
I will tell you, I don't mind that. I know some clinicians do. I don't. It makes my job easier. There was, when I grew up, there was a store, a clothing store where I grew up, called Sims. I think it's kind of, but a well-educated consumer is our best customer. I mean, that's kind of how I feel like, because as people in prostate cancer, when they start doing their homework, they become aware of the side effects.
yes.
But to answer your other question, and I cut you off, but I'll answer it anyways. Some people, you can't make them become rational about it. Some people, my nurse hates when I see a new prostate cancer patient because it's a 45-minute visit to an hour, and she wants me out of there in 20 minutes. I don't blame her. But I don't think you can always do this in 20 minutes. Some people, I will talk to them for an hour, and they will not, no matter what happens, they are not going to change. I'll give you an example of a patient who saw me once because he didn't like my response. And but he basically came to me at really bad prostate cancer. And I said to him, I said, listen, he was young, he was in his 50s. And I said, you're going to need to have some sort of treatment. And I think you should stay on the reservation. I would tell you that, we don't see any sign of spread. We're going to do surgery. You're probably going to need radiation afterwards. Down the road, you may need hormonal therapy. And he had read online about some clinic and I say this with a little disdain, because it is, on the Kentucky-Tennessee border that was giving patients IV doses of heavy metals, you know, and no matter how much I tried to rationalize with him, and he had made up his mind, and it was irrational, sometimes you talk to people about surgery and they say, well, there's a, you put air in there, the cancer spreads, makes cancer spread. That's a common, old wives' tale, at least down around here. Yeah, I see patients who come and say that to me. And some people you just can't sort of get them to take the emotional charge out of the diagnosis. You just can't. So you got to work with that, right? You just got to. But most people, if you start talking to them and start saying, okay, you have cancer, let's stop for a minute. The good news is it's prostate cancer. And even the worst prostate cancers tend to be slower growing, and so you have some time to make a smart decision, and you can be a little bit more clinical about it, for lack of a better way to put it. And we can talk about the different options. And that's where I do think, if someone goes and looks on the internet and does, their homework, they're going to make a better decision. And I appreciate that. It's the guy who comes in and starts critiquing my papers. I've had this happen. Well, how could you say this, this, this? I'm like, look, that's just what I think. That's what I think the data show. Well, I think that I don't want to argue about the research. We can do that at a conference. Let's talk about what you want. Well, I'll do it for you. I'm simple like that, but I think it's very hard to sort of turn down the emotional volume, because the word cancer, it's not just any human hears that, and it scares you, right? And that goes back to what we were saying before about maybe we shouldn't be calling Gleason 6 cancer, because there's a charge that goes with that word that freaks people out.
Yes. Actually, I want to go to where you're going right now, which is in that preference set, and in the option, I should say, actually, in that option grid, you have surgery, you have radiation, you have active surveillance. And prior to us having this conversation, I had equated active surveillance to, I'm just going to say this, in the do nothing camp. I know active surveillance is not do nothing, but it's the closest thing to do nothing, right? Which in breast cancer, in the absence, there is no active surveillance in breast cancer, right? I mean, you could argue DCIS, but not really. Like, it's not really treated the same way. My question for you is actually, is there truly a do nothing option?
Oh, yeah.
If you think of the anxiety level in active surveillance, to your point, your anxiety level is kind of your comparator to the symptom burden of surgery radiation. It really is, anxiety becomes kind of your symptom in quotes. Is there really a do nothing, like true option?
Yes, there is. All right. So you think about anxiety with active surveillance. I don't think the anxiety is relative to I'm going to give you a little pushback to the treatments. I think the anxiety is, for most patients, you told me I have cancer and I'm not aggressively fighting it, right?
Oh.
That's where I think the anxiety comes from. I don't think the anxiety is, I should be about the side effects of treatment. I think it's
Interesting.
You said the word cancer, doc, and I'm just following it. All right. So that's that piece. If you are of the mindset that, hey, listen, I have low-grade prostate cancer, and odds are it's not going to cause me any problems, and I've thought it through, and I understand it might, but it's a really small risk. So I choose to ignore this. That's watchful waiting. And that's reasonable.
Interesting.
I mean, people talk about it. Part of it is age too. So if I'm 58 years old this year, if I had low-grade prostate cancer and I would want to follow it. I'd want to have active surveillance because I have this, hopefully, 30-year window during which perhaps it could get worse. Perhaps it could, de-differentiate down and get, maybe Gleason 6 is a marker for bad stuff coming down the pike if I live long enough. Conversely, if I was 78 and you told me I had a single focus of Gleason 6, I'd say, well, I got 10 years if I'm lucky, right? Maybe I shouldn't be worrying about, getting my PSA checked. And that's one of the real challenges in active surveillance, which we're working through, is when do you go from active surveillance to watch or waiting? But you could make the argument at age 50 something that you have Gleason 6 disease, you understand there's a risk, but you're cool with it. Because if you look at autopsy studies, there are a lot of people who, the old expression, more men die with prostate cancer than of it. That's true. And most of the guys who die with prostate cancer and they find it on an autopsy, it's low-grade disease. They're finding Gleason 6 disease in guys in their 40s and 50s, and the majority of those guys are not going to die from prostate cancer. So you could do that. Now, again, my preference set at age 58 would not allow me to do that. And I think most patients are not going to be comfortable with that. And I think, frankly, then you get into doctor think, right? And I'm a doctor, I think this way, where we are risk averse. It's not about, people think it's about the money. It's not about the money. It's risk averse, right? Doctors, it's not my place to make that decision for you.
Yes.
Right. So I think that's what you get up against. But yeah, quote unquote, doing nothing, watch or waiting, it's a reasonable thing to do. Would I do it if I had Gleason 8 disease? No way. But there are people who talk about it.
I'm watching the clock out, and I can tell you that our conversation, I could talk to you for hours very, very easily, very easily. But I think our listeners at some point are going to be like, you guys need to like.
Yeah. It gets prostate. It's like my wife. Can you just stop talking about it already? I mean, can we talk about something else? It's fascinating. It is a really interesting topic, and we're just scratching the surface with it from a patient perspective. Just because it's a unique cancer in that it is relatively slow growing, and so the threat to life and limb isn't perhaps as great as if you have, say, pancreatic cancer, right? And all the treatments have side effects, and even screening has side effects. So it's cool. And if you're into decision science and patient preferences like you are and I am, yeah, we'll talk for hours about it. And no one wants to listen.
Okay, so my last question to you, and we're going to use that as a wrap-up question, is you've been in the space for decades. If you look out another decade and you had a magic wand and you cannot eradicate cancer, none of the like cheesy, corny answers, sorry. What would you change about what we're talking about? So patient preferences, decision-making, and you could change anything.
Yeah. I'll tell you, when I was, again, a resident, so this is going back 25 years, and we were doing radical prostatectomies, I used to say, I'll never be, 20 years now, we'll never be doing this operation. We're going to have some medical treatment and we'll have some cure. And clearly we're still doing this operation. I will say there are two things, one thing I wish for, and one thing I think that is we're going to see. And we didn't even get into some interesting math about screening, which is with effective treatments for metastatic disease, screening becomes less important in prostate cancer. So what I think we're going to see is the ongoing parade of immuno-oncology drugs, which are really game changers. Cost aside, whole separate discussion. But I mean, these drugs, we're seeing, these drugs have activity in advanced disease. And at some point, when the cost curve makes sense, people might even try looking at it in more advanced disease, in more locally advanced disease, maybe even high-grade localized disease. So medical therapy is going to play a bigger and bigger role in prostate cancer. I really believe that. And if I'm wrong this time, it'll be, I've been wrong now for 20 years about that one. So, and I would be happy with that, if you said, what can you wish for that's realistic beyond magically. I wish we had a good biomarker that could distinguish between clinically significant and clinically insignificant disease. So in other words, and Gleason 6 is a good way to go, but there are problems with that. The folks on the colic cancer side will say, beyond the pathologic orthodoxy, oh, well, you may be missing worse disease, you may be undersampling, blah, 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 blah. And that's all true. But if you could give me a biomarker test, whether it's from the tissue or from the blood, that says, you know what, 9 times out of 10, preferably 100% of the time, but let's say really reliably, I can tell you that this is going to be a real cancer, you need to treat it. And this is a nothing cancer, don't worry about it. That would make a big difference, because then you really could switch from active surveillance to do nothing, right? You could really call that cancer something other than cancer and really sleep well at night. That's what I wish for. But we've been wishing for that for 25, 30 years. We thought we had that with the genomic tests. I don't think we do. People talk about biomarkers, imaging. Now we have PSMA imaging. Maybe that'll help. But but I'm convinced the medical therapies are going to advance and they're going to move downstream to localized disease. I think that's going to be a really good thing.
That is such a profound answer. And I absolutely hope that your wish comes true. That would, I think, change how we navigate cancer, or not call it cancer at all, which would be
yeah, exactly. So at least for prostate cancer, I don't know about many other cancers. So,
Dr. Penson, thank you so much for joining us. This has been
thank you for having me.
Pleasure, and I
appreciate it.
Certain that a lot of patients and families are going to benefit tremendously from these 2 episodes. So, thank you.
Thank you.
This episode was supported by an award from the Patient-Centered Outcomes Research Institute. This podcast, show notes, and newsletter is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or any materials linked from this blog is at the user's own risk. The content here is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition they may have and should seek the assistance of their healthcare professionals for any such conditions.